Well, welcome, everybody. I'm delighted to see so many people here today. I must just pay special tribute to someone on the front row, David Hogarth, who left London on a bus at 11 o'clock last night and arrived at 6 this morning, which I think shows huge devotion to the CQC, David. But welcome to everybody who's here today. We've got no apologies for absence. Everyone is here. Anna is joining us in a minute. The minutes of the last meeting, everyone happy with the minutes? There's only one matter arising which has been dealt with, which is not dealt with later, and that is that we are not going to do the thematic review onto microbial and infectious diseases. We're not going to do that, I think. Paul, we're not doing that. Excellent. So, Chief Executive Report, David.
Thank you, Chair. Good morning, everybody. You'll have a supplementary paper to board colleagues in a brown envelope. I'm not sure what members of the public will have, but there'll be a report entitled, it's number 11, and it's called The Response to the Mid-Staffs Inquiry, which came out because this is a public agenda. The report was published yesterday, so in the update that I'll make, I'll also touch on that report and the Post-Francis report, if I may. So just turning now to the report, it's really an update on progress against a number of key issues. Significantly, we've had a report back from a gateway review that has been taken place of our preparedness in relation to the transformation programme. The purpose of these reviews is to assess our readiness to actually take forward the changes that we are proposing as an organisation. That gateway review is now completed. It provides external scrutiny by people that are not connected in any way, shape or form with CQC. They have rated the programme amber, which is effectively a judgment that says good progress is being made, but there is risk to delivery unless action is taken against a range of other issues. They effectively made 5 recommendations. Those recommendations touched on slimming down the governance that we've got in place. They thought that was too heavy of touch and needed to be lighter of touch, and a greater focus on what the deliverables are and what the, in inverted commas, the end state is. So effectively, they were saying less process and more focus on what it is that you're going to deliver by when. I would add that a number of people, including myself, that have been through these gateway reviews, to get an amber review on the first is actually is good. Most are rated red or amber red. So I don't want us to be complacent about this in any way, shape or form. But it was good to get that independent review and that independent judgment. We've asked them back in July of next year. That's to get beyond the 1st of April implementation dates for a lot of our work, and then give us 3 months to see it embedded in, and then come back and say whether that is the traction that we wanted to see has indeed been seen and that there's delivery.
Yeah. Hold there. Anyone like to come back? Any questions on David on the Camilla? Yeah.
Just could you say a bit more, David, about what they mean by slimming down process?
Yeah.
Give us an example.
I think we've got too many meetings. Does that play to the point? Too many meetings that duplicate too much. So I think we've obsessed about interdependence. So we have meetings to make sure that this piece of work and this piece of work are connected. And they're saying you don't need a meeting to check that out, which was a good challenge. So we're culling meetings really to make sure that we're clear enough about what needs to be decided. I think the other issue is be clear what's a decision-making meeting, and be clear what is a meeting that's about planning and design, so you're not confusing your decision-making governance with the planning and design work that you need. And again, a good challenge, I think. And if you're not clear, these can turn into talking shops. So they're really saying just really cull it and be brutal about why you're meeting, what the purpose is. And you don't necessarily need to meet to get your interdependencies right. You can do that in other routes. So make sure you've got a person that's in common that is charged with ensuring independence. So it was quite practical, pragmatic. And I have to say, very helpful, conducted in a good spirit. And they were very, very complimentary about the openness and the approach of the staff that made a contribution to it as well. So it was a good example of external scrutiny being of a help.
Okay.
So, yeah, firstly, congratulations to, you know, getting such positive feedback from the Gateway Review. I think there were very valid comments, actually, and I know we're still sort of developing our approach, but I think particularly the comment on what the end state will be is perhaps, I mean, I'm certainly not clear on that. I mean, I have a general idea what it's like, what it's going to be like, but I think you know, it would be helpful to know when we will be sort of clearer on that.
So, okay, there's documentation on this being worked up, and as a consequence of the challenge, this was already being prepared, interestingly, in terms of what the Gateway Review have come back. But we'll bring that to the December board, and I think it'll be in a good state then. Not finalised and not finished, but it'll be in a good state, I think. And I think we've been able to develop it as a consequence of the review as well, and the challenge that they provided. As I say, they were very constructive, as well as giving a challenge about why we're doing things. So the next few paragraphs are really updates. I'm updating on the next few paragraphs are updates. We will be publishing in the next few weeks signposting documents similar to the ones we've done on hospital inspections and adult social care, on mental health, community health and primary care. I'm reporting on the hospital inspection programme elsewhere. There's a performance report, so I'll not dwell on that, Chair. Care Bill has completed its third reading in the Lords and will go into the House of Commons, and we'll get a second reading. A date hasn't yet been announced. Yesterday's announcements in relation to the response to Robert Francis will inform those debates as it goes, as the bill goes through, and many of the initiatives announced yesterday require legislative action, and so we'll see that work its way through during the next few weeks. We are working with the department, and this also plays to the announcements yesterday, on the development of regulations. That work is active. The significance of this is we need the regulations to go out for consultation, so that we can then take the reformed regulations into our methodologies, consult on those, so we're good to go from the 1st of April next year in terms of changing our methodologies around hospital inspections. Currently, we're enforcing any enforcement action with our new inspection will be taken under the Health and Social Care Act, as distinct from the regulations that exist from that. What we want are new regulations which give force to our new methodologies, so we enforce our new methodologies. So this is the oil and water of the old and the new, which are currently mixing to give us our legislative position, but we do need these new regulations. So that work is going on. We'd anticipated they would be available by now, and they're not. So what I'm flagging here is that there's work going on, but there's a consequent issue that we may need to address, which is we might not be good to go on the 1st of April. So just to be clear about that. If I may now, David, on the mid-Staffordshire inquiry, just turn to the supplementary paper, paper 11. The reason this came out is that we put our papers into the public domain when they're published on the Friday. But because there was an embargo on saying anything about mid-staffs, this paper was circulated to the board members but went on our website at 1:30 yesterday when the statement to the House of Commons was completed. And if I may just go, for colleagues that have got the paper, to paragraph 3.2, which I think is a helpful summary of the highlights of the announcement that was made by the Secretary of State for Health yesterday, which really do begin to pull out from the government's response to Robert Francis's report some of the concrete measures which are being taken forward by the government and indeed by yourselves. Clearly, the work that we've been asked to undertake in relation to a new inspection regime, the consultation, the appointment of our 3 chief inspectors are all part and parcel of the response that is being made to Francis. Yesterday, a lot of media attention was paid to the issues around staffing levels and should these be mandated, should they not be mandated. Coverage also to the implications of the statutory duty of candour, the issue around criminal offences in relation to behaviour, and this balance between creating a learning culture within health and care services and an accountability culture, and how that balance was struck. I thought what the Secretary of State was doing yesterday is trying to strike that balance between a learning culture and accountability around criminal offences. Many of the criminal offences will require legislative background, and the duty of candour will also require regulations to give them force. And that's the significance of the point that I was making a few minutes ago about the importance of the regulations and the consultation on the regulations to allow us to move forward. One of the key points I think the government wanted to land yesterday was the fact that of the additional reviews which have been undertaken, they were arguing that their response is to accept the majority of those recommendations. Consequently, coverage took place about those which were not accepted in full. Robert Francis's approach to this yesterday was to say he was satisfied with the way that his report was being taken forward because, and this was his argument, there are many different ways to take forward recommendations, not to do it just in the literal way that he set them out. And he felt the ambitions that he had for the changes to take place in the culture of health and care services were being taken forward. I don't want to speak for him in that respect, but he was very supportive of the proposals which were being taken forward. So that's what 3.2 is attempting to catch. Yeah.
Mike, I wondered, I was going to pick out a couple of these issues, and the issue about staffing levels has obviously been a key one, and I think it would be helpful if you gave your view on staffing levels.
Thank you, David. We've discussed this at length, both within CQC and with the Secretary of State, and indeed with Jane Cummins as Chief Nursing Officer. My feeling is that what really matters is for, at a ward level, every ward to be assessed for the acuity or the dependency of the patient so that the expected or the planned staffing level can be established. And that needs to be done at least a couple of times a year because things can change in terms of what the average dependency is. So you set your planned level and then should report against that, and the statement yesterday was that people should, on a monthly basis, report actual against planned. I believe that this is a very sensible way forward because the needs on different wards are very different. If you're on a hyperacute stroke unit, you may need a ratio of 1 to 4. On a paediatric ward, depending on the dependency, it might be 1 to 5, something like that. On other wards, it may be 1 to 8. I think there's a real risk that if one says just 1 to 8, that could become the norm, and there could be a levelling down, and I think that would be a great disadvantage. So I think the responsibility has to be with the Trust Board to set the staffing levels and monitor them against that. And then, of course, we as CQC will be able to use that information, and will indeed use it. And we'll use it alongside information on safety. So information from the safety thermometer, which measures things like pressure ulcers and falls and venous thromboembolism rates at each ward level. And indeed against the friends and family test, which we already have at ward level and which we are already using. So in our data packs for our acute hospital inspections, we have the friends and family test results by ward, and I can look down those very quickly and I can say, well, whatever else, we must go to those wards because they've got the least good friends and family test. And we will always go and see a range of wards within any hospital. So I think this combination of getting them to set their staffing levels, measure against it, and put that alongside good safety data will actually be very powerful.
Anyone else like to pick out any? Lewis, yeah.
This is partly about staffing, but partly about the report in general. I must say I'm relieved to hear, David, that you felt the balance was properly set between culture and the use of the law, because I think what came across was the use of the law rather than culture. That would, if that were allowed to get around, I think that would go down badly with staff who would otherwise respond well to the ethic of learning, the phrase that Berwick used. It's the ethic of learning that we need to focus on. Yes, let's have legal measures that occasionally take people to court if they've done something willful and reckless, as Berwick said. But otherwise, this is about changing the culture of the service. And our messaging, I hope, will be focusing on changing the culture of the service and not on the legal measures, which may be used in extreme cases, but which Berwick himself said would have very little effect on safety. On the issue of staffing, I wouldn't underestimate the potential for gaming on this. When I was National Director for Mental Health, I thought it would be helpful to publish per capita spending on mental health nationally by PCT, because there was such a lot of controversy about the variation, and so we did publish it. And then I began to hear that the PCTs that had come out rather well were starting to say, well, we're spending too much on mental health, it's about time that we were spending less, because we're sort of outliers at the top end, so to speak. And the detail here will be crucial, Mike, as I'm sure you're well aware. There's even the KEO review into some of the trusts a few months ago commented that the information that was being given to them by trusts was not accurate, which they discovered when they went to do inspections. They said that people were recorded as having a certain level of staffing, or trusts having a certain level of staffing, but that didn't reflect the seniority and experience of the staff, which was not adequate. And they didn't mention the fact that some of the staff who were being counted were agency staff. Now, these things will have to be overcome, otherwise the system will be discredited. I've got two questions, if I can, very quick. One is, do we know any more yet about what is meant by the greater independence of CQC that the Secretary of State has referred to? And then finally, a very particular CQC question. I was slightly surprised to find that there were a number of compromise agreements that we would have to write to staff about. So these are current compromise agreements, or currently in place, if I've understood that. How many? Do we have any idea how many such agreements are with former employees there are?
Thanks. Let's do those in reverse order. I think it's 29, but let me check that and I'll give you the figure. But I don't think any of those have got gagging clauses, so what we're asked to do is actually write to make sure that there is nothing in those, and confirm this in writing to each individual that has had a compromise agreement, that there is no way that we expect them or debar them for speaking out if they've got a genuine concern. So that's the nature of the letter. That's effectively what the Health Select Committee were asking us to give further reassurance on, that those confidentiality agreements were not going to be used to stop people speaking out if they had genuine concerns. And we'll do that, and we've confirmed we'll do that by the end of this month. They are historic. They go back to the beginning of CQC, which is why I just can't do the figure off the top of my head, Lewis. I think it's about 29. So we've confirmed we'll do that, and arrangements are in place. In terms of greater independence, effectively what this means is an example would be under the current legislation, in order to do in inverted commas a special study, to use our section 48 powers to do a special study, the way the current legislation is drafted is we'd have to consult with the Secretary of State to do that special study. And what the greater independence does is it removes any requirement for us to ask the Secretary of State for permission to discharge our responsibilities. And it affirms our operational independence from the Secretary of State. So any judgments that are made about the quality of service, and indeed any ratings that we issue, are done by CQC. The board is a legal entity, and the delegations will see those judgments being with each of the chief inspectors, and it affirms, in a sense, the independence of that operational decision making. So that's what it will give force to. It will remove that. I think on the wider point about this balance, I think it feels like we've been preparing for what we're going to say about Robert Francis's report for a long time. And I thought the watershed yesterday was actually this is now about delivery. This isn't about the arguments about who's going to do what and how. This really is about getting on and doing it. I think we've been doing that to a certain extent by the fact that Mike's overseen 13 of these 18 inspections being done, and we've so it felt from my point of view positive yesterday to be able to say not we intend to do this, but we are doing this. And I think the fact that we've got the surveillance out in October, we've got the inspections underway, and the 4 reports published tomorrow was a sense of that we've begun to do this. So this will become something that we do rather than something that we talk about, and I think that was the measure yesterday. And we just got to strike that balance between accountability. I thought Berwick's report, without using this phrase, was another exposition of what a just culture is, about how you get that balance between supporting and having an accountability at the end. And it's something that we've talked about in CQC, and certainly I think influences the way we're trying to build and design both what we do internally in CQC and what we do in terms of our methodologies. So it's to play for, I think.
I'm just going to ask Anna, but just before I do, I mean, just to the 3 chief inspectors, I mean, that point that Lewis made and that David just referred to, getting this balance right between accountability and learning. I think we're all at one on this, aren't we? That it's getting a learning culture into these organisations is the most important thing. Is that how you 3 of you see it?
I would certainly see it that way, and we can already see that some trusts do have that learning culture, and others have it to a much lesser degree.
I would agree completely. Just as a note on staffing, when we start to look at general practice and primary care, I think there are staffing issues there as well, particularly a warning for any GPs watching this board meeting that I can't see how general practitioners can deliver their services without nurses. And we're finding examples of GP surgeries without practice nurses. And so whilst the attention's been on hospitals, I think there's a real issue in primary care as well. And it's this balance when we do our inspections about making sure we've got safe and caring and well-led organisations, but also that we support and we recommend from a development point of view that they focus on the services they provide as well.
Yes, and two things. One, on the balance between the learning culture. I mean, I think that's where the question about is the service well led really comes into its own, in terms of looking at are organisations aware of what they need to be supporting their staff to deliver, and making sure that those arrangements are in place. And it's, you know, it will be a critical aspect of the questions that we will ask in adult social care. Equally, I think that on staffing and actually on quite a lot of what's written from the Francis report and Mid Staffordshire, there's a lot of read across from the NHS into adult social care. And I think that one of the things that as a collective organisation at CQC that we need to do is to make sure that we're learning the lessons from the health service into the social care sector as well. And that's what we will be trying to do in looking at questions around safety and effectiveness and caring as well.
Very much. I just wanted to pick up on what you were saying, David, about moving from kind of waiting for all the responses to Francis and all the associated reports and into delivery, because I mean I think it must be a good thing for us in terms of the sort of uncertainty of the environment in which we operate, that you feel that we've got to the point where actually everyone has acknowledged that's the set of answers at least to this report. And I know there's no accounting for events and circumstances which could throw us off course again, but bearing in mind the set of work which is now foreseen in this final response, how long do you, what's your kind of, I know it's a slightly finger in the air at the moment, but how long will we be working on this set of propositions, do you think, before we can feel that we know exactly what we're doing in relation to each of these things?
So I think we set out a 3-year strategy at the beginning. I think much of the thinking about this is a 3-year journey that we're on, stands. I think there's an issue about CQC is running red hot at the minute. I think that's the other thing that came from the Gateway Review, that we are running very, very hard and very, very hot. Normally in a Gateway Review, they'd say you're running too hot, put something in there to cool it down. But they acknowledge that we've got a whole set of things that we're committed to do by due dates, and running hot is what we need to do. So a lot of their advice was about slimming it down, being more efficient about what you're doing, so you can deliver what you've set out to do without putting too much effort into the kind of process of it. I think our public statements about what we will do by when, and I think this is the significance of the signposting documents, which are beginning to say this is what we're going to do by when, this is the detail we're working towards. These are hugely important documents for people that we work with, stakeholders, people in the system, to get a sense of what we're doing. It'll be the first thing that we'll have said of this is how we think we're going to do our work on mental health, this is how we're going to do our work on community healthcare services. So it was a signal to the system. These are hugely significant documents. It'll be the first thing that Steve's actually said in writing about what we're going to do in the future. So I'm confident about that work. I'm confident that we're bringing in the capability and capacity through some additional consultancy. I know we'll talk about those issues later this morning. But by bringing that additional capacity in, by being clear about what we intend to do by when, I'm confident that we'll do the work that we've set out to do. I think the important thing, and we got this question at the Health Select Committee, and we're getting it a lot about, are you giving enough priority to this? Do you not think you should do this more quickly? And my answer at the Select Committee is, you can't have it all ways. If everything's a priority, nothing is. And therefore, I think my job is to hold our collective nerve about this is the order we're going to do it in. And there'll be all kind of people that want to push us into doing things sooner rather than later. And I think that what I've got to do is calculate whether that's possible, whether that's a reasonable request, whether we should change priorities or not. We shouldn't say these are the priorities and therefore stick to them, but we constantly need to be judging it. I think Mike's point about staffing levels in organisations is you've got to be constantly reviewing them and judging them and whether you've got the right people in the right place doing the right things. And in the same way, I think we've got to constantly review and judge whether we're doing the right things in the right way. And that's what we'll do. So yes, I'm confident, but we're running hot and there's risk.
Right. We'll take just one more question now. It's Jennifer.
Government responses of this type often contain a collection of practical things, as is shown in the list in 3.2. But underneath all of them, as we know, is well-ledness. You know, and that's a big feature of Francis, the board, the role of the board, the role of management. I wonder whether we, as a board, in our forthcoming strategy session, we should really give well-ledness a really big chew the cud a lot more on it with respect to the government's response, whether we think there's more that we could be doing. And also, similarly, with those in Monitor and the TDA on the acute hospital side, to make sure that we have there is some kind of consensus about what we think well-ledness really is, because it really does underpin everything. And we could send a very powerful signal, couldn't we? And I know there will have been quite a bit of discussion on this already, but I do think in the light of this, because it doesn't come out in the headlines you've said, whether or not we should revisit it in our strategy with Monitor, and then that might set the scene for the general practice and the social care side if we've bottomed it out a little bit more. I think it's worth some attention.
It's a very good point, Jennifer. I mean, we are doing the work with the King's Fund, as you know, I think, and with Michael West at Lancaster University to come up with a more definition around the well-ledness. We're doing that with Monitor as well, so that the two are completely joined up on that. But I think at December we'll come back to you and show you what's been done in December if we can. It is absolutely underpins everything that's going on. David, do you want to finish off your report quickly?
Yeah. So if I can just go to paragraph 8 in the report, the Human Factors Concordat really links to this. This was one of the supporting papers published by the National Quality Board. which really takes some of the thinking that Berwick and others have used and publishes a separate, think piece really, a concordat, which is saying people will work to this. After this report was produced, the NQB also published a report on staffing levels as well, which informed the debate yesterday. Paragraph 7, I'm drawing attention to the terms of reference which Dr. Bill Kirkup has announced in relation to the method statement he's going to use in relation to the inquiry that he will lead in relation to maternity services at Morecambe Bay. A number of current and former staff may be called to give evidence at that inquiry. They've been written to advise of the terms of reference of the inquiry and prepared for the fact that they may be asked to make a contribution to that. It's not an inquiry into CQC, it's an inquiry into maternity services at Morecambe Bay. But clearly, as CQC regulated those services, it is likely that we'll be asked to make a contribution to it. And the last thing, David, on the report is just to update that we're now underway for recruitment to Deputy Chief Inspectors. I think Mike's shortlisting Thursday in relation to those posts, and both Andrea and Steve are in conversations in relation to the Deputy Chief Inspector post to support their work, and that work will be completed towards the end of the calendar year and probably creeping into the beginning of next year. Just to confirm that you and I interviewed, and we have an offer out to somebody to become the Director of Corporate Services. We're just doing the due diligence on that appointment, and I hope by the next meeting we'll be able to announce a name. Colleagues internally in the organisation are aware of where we're up to, but there's further work to be done on that, and as I say, we'll announce that shortly. So that's the report, Dave. Thanks.
Any last questions for David? Will we move on? Mike, your report, please.
Thank you very much indeed, David. You all should have the report. I'll just go through it very briefly. We are well underway with wave 1 of the acute hospital inspection programme. As people will remember, we aim to inspect 18 trusts during this period, and those were selected as being a combination of ones that we thought were high risk, we thought were low risk, and we thought were intermediate risk. We have got at least to the site visit stage, the planned site visit stage, for 13 of those 18, and they're listed there. I won't go through them all. And for the first group of 4, we have got through to the final step in the process, which is the quality summit, those were held yesterday. I was at the one at Airedale, and that quality summit has sitting around a table, apart from ourselves from CQC and representatives of the trust, representatives of Monitor in that case because it was a foundation trust, the local CCGs, Health Watch, the local Health Watch, and NHS England, and we presented our report, and the plan is that that report will be published tomorrow, and the trust then responded to the report, and then the third part of the meeting was action planning. That section is led by Monitor as opposed to by us, because clearly we are not responsible for doing the quality improvement, but we were party to that so that we can at least hear what is being planned. That will help us also to know when we might want to go back in. So I think for at least that first group of 4, we've now got through to that sort of third step in the process. I think the informal feedback has been positive so far. We're doing a formal evaluation, but that will only come through when we've completed wave 1. But I think what is also important to say is that with almost every inspection, we are modifying the process a little bit in the light of experience. Probably the most important things are that we are recognising how important it is to get information before we go on site. and sufficiently far in advance that we can have read the information, whether that's the board minutes or whether it's complaints or information on reporting of harms, that sort of thing, so that we can really have taken that on board, and that can then direct us to where to go and direct the questioning that we may want to put to the trust. Equally, we have a training and planning day before we go on site in earnest, but we've brought forward the presentation that the Chief Executive gives to that day. This is very helpful because it really gets the inspection team focused on what the trust is all about, and hearing it from the Chief Executive, and then we can often have a first bit of informal inspection that evening. And we are also, as you know, committed in the future to giving each trust a rating, and what we really want to do is give each service within each trust, each of the 8 core services, a rating, and we want to rate against our 5 key questions of safe, effective, caring, responsive, well led, and we are testing that and testing whether we've got enough information and whether we can get enough information to effectively complete the grid on that. And I think we're making good progress, but it is still early days. So, I mean, I'm certainly not saying that everything is going as we would want it to long term, but it is going, and the trusts that we've been to have been very courteous and have also said that they've come back with positive comments on how we've gone about it, and so I think all is okay but could be improved. We will start wave 2 in January, and we've listed the 19 acute trusts in wave 2 at paragraph 8. We've deliberately chosen, again, some that we think are high risk according to the intelligent monitoring tool, deliberately some that are aspiring to be foundation trusts, because as board members will know, Monitor wants to have assurance from us about the quality of any trust before giving it the go-ahead to become a foundation trust. And we're also starting the process of re-review of the KEO trust, the 14 of those. We've got to do those all before the summer, so we're getting some of them done before Easter. So that's the acute side. On the mental health and community services side, we're making rapid progress, but as I've said before to the board, we are committed to having parity of inspection as well as parity of esteem, by which I mean that we are committed to getting through to the end of the community and mental health trust inspections by the same time as we will have done for the acute trust, which is December 2015. But we do recognise that we haven't got the KEO model as such on which to build. We believe, and we've had lots of work with external reference groups on this, that the same broad principles will apply. In other words, getting as much data in as we can before we go on site, taking a large team with us, and visiting lots of different areas within a trust, and then the report back and quality summit. But obviously, what we consider to be core services within community health or mental health will be quite different from the ones that we would say for acute services. One of the challenges will still be, can we visit, or what services should we visit, because they are scattered over large geographical areas, and a lot of the services are given in people's homes, and we can't possibly inspect all of those. And we are taking, again, an approach which is based on where we think the highest risks lie. So, for example, all inpatient services we feel that we should assess. And I think another thing to say is that the level of data we're likely to have before we go on site, either for mental health or community services, will not be as detailed as we have for acute. I'm not saying it's perfect for acute, it isn't, but there is still some way to go on that. We will be more reliant on information provided by the individual trust rather than on national benchmarking data, but we're working with community trusts, for example, to say what data do you all think you would all be able to provide and what would be useful. So that is work in hand. We have identified 9 trusts and services that will form part of our Wave 1 for mental health and community services. 4 of those are mental health trusts on their own. 3 are community health trusts on their own. 1 is a combined mental health and community services, and 1 is a combined acute and community services. And if people are really on the ball, they will have spotted that St George's is in the acute list and is also in the community list, because it is that's the one. And our thinking there is that effectively we will run 2 teams in parallel. Because the people we will need for a community inspection will be quite different. There'll be health visitors, district nurses and others from the acute, but we will run those in parallel in the same way as when we were inspecting Barts Health, which was obviously huge and included Whipps Cross and Newham as well as the Royal London and Barts. We ran effectively 3 separate teams in parallel. We might well run 2 teams, but with the relevant expertise in parallel, but almost certainly staying in the same hotel, so that we are feeding back and exchanging views, which will contribute, I think, very much to how well led the trust is as a whole, and that bit which will overlap distinctly. The final bit you asked at the last board meeting for an update on involvement of patients, users and carers in the hospital programme as a whole. We obviously already do have them involved in the acute hospital inspection programme. We tend to have 5 or 6 experts by experience on each of our inspection teams. What that means is that they can then split up so that there is 1 on each sub-team. So there will be a sub-team looking at A&E or a sub-team looking at maternity, or 1 looking at medical wards, etc. And so that the idea is that on every one of our sub-teams we do have an expert by experience, and we are finding their input hugely valuable. So that's the sort of formal side from our side, but we are also obviously trying to get as much information as we can about users of the service that we are inspecting, and there are a number of ways we can do that. There are the surveys, the one that the CQC runs, the inpatient survey, there's the cancer patient survey, and increasingly there's the friends and family test. That gives us a lot of information. We are also, in advance of going on site, doing more and more reaching out to specific local communities. An example being the week before we inspected Salford, there had been engagement with the local Jewish community, and that provided very useful feedback in advance of our visit. We have a listening event on each of our inspections, and increasingly we are also getting a patient perspective by analysing complaints. That's something that we were only starting to do, but I think really from this next group we will be doing more and more of. So, and we are open to suggestions about what more to do on any of those. So I think my conclusion is we are now well underway. There's lots of modifications that we will make. We've got a small break between wave 1 and wave 2, in which case we will reflect and try and improve, and then we'll get cracking with mental health and community services.
Thank you very much, Mike. Questions? Kay first. Yeah.
Okay. Thanks, Mike. I had the opportunity to join one of the inspections for a couple of days, and the thing that struck me the most was the sort of enthusiasm by various sort of clinicians, workers, patients, experts by experience to actually the enthusiasm to get involved and to help us get it right, and also valuing the opportunity, and I think that's a real kind of positive. So I had 2 kind of questions. One I think is about the evaluation, and 2 aspects. One, the intelligent monitoring tool. Is that going to be part of the evaluation? Because it's important we get it right, and it's not perfect, and I sort of certainly value some assurance that it's as good as it can be, and and to sort of understand the limitations, and to make sure that we understand the limitations as well, and our staff do, and also in terms of probably the evaluation. I know that when we did our consultation on our strategy, there was some people that felt that the standards, the fundamental standards or the expected standards, there wasn't sufficient clarity. And so I wondered, from the first wave of inspections, whether it's becoming clearer to us how we are going to define them, explain them, and assess against them, and whether that's part of the evaluation. And the final point is on the mental health inspections, we're prioritising those that want to be foundation trusts. And why aren't we prioritising those that we think might be at high risk? Because to my mind, that would be, from a patient perspective, that would be the most appropriate.
Right. I agree with you about the enthusiasm of the teams. It's huge. In terms of evaluation, the evaluation will look at everything that we are doing, and we have an external team who are accompanying us on these inspections, but they're looking at all aspects of it, and I think you may have met some of them. The intelligent monitoring tool, and Paul may wish to add to this, I think one of the things we're testing in Wave 1 is what is the relationship between what we saw on intelligent monitoring and what we see when we get on the ground. And frankly, until we've done all 18, I don't think we're in a position to judge that one properly. So in other words, do those that appear to have low risk look good or whatever when we're there, and do those that appear to have high risk actually have lots of challenges? So I'm sure we will report back to a board meeting in the future on that, but I don't think we're quite there yet. Equally, exactly how we put the intelligent monitoring tool together, Paul is probably in a better position to speak about that, but what we have done is to try and include those indicators that we think are robust at a national level and that cover all 5 questions. So that's the balance that we're going for, and certainly I find it a useful starting point, but I don't think any of us are expecting it to be the be-all and end-all. If it was, why would we need inspection? You know, I would have a very, very easy job, because I'd just say, Paul, give me the intelligent monitoring answer, and that's my verdict. So it really is a combination of what we see in the data and what we see on the ground. The fundamental standards, well, as you will know, the fundamental standards are in the process of changing. In this phase, of course, what we're saying is where we see serious breaches of standards, we are still taking the same action as we would have done in the past, and you know, we will be issuing warning notices where that is appropriate. And that is part of the value of having experienced CQC inspectors and compliance managers on the team. They understand that business very well, but it is also about getting people to understand that the new inspection programme is about looking for what's good as well as what's not so good, and I think that is quite a fundamental change in some ways. In terms of the mental health inspections, we don't of course have the same intelligent monitoring tool yet to say to us which are the ones that are at highest risk. As soon as we've got to that point, I am sure we should investigate and assess those that are at high risk. We are very much being encouraged by our colleagues at the Trust Development Authority and Monitor to get some of these ones through, and I think what we feel is that at this stage we can develop a good enough approach to assessment to be able to make that judgment, are they ready for foundation trust status, but it'll take us longer to get to the point where we can really rate a mental health or community service trust. So we're in a learning phase basically.
Lewis?
Thank you. Well, my first question was going to be the same one that Kay asked about the link between the surveillance and the inspections. Presumably in the end, that is one of the key questions which the inspections are asking, not just about themselves, but about how they got there in the first place. And of course, among all the questions you could ask about that, there's one that is more important than any other, that is about the false negatives. So it's where the surveillance says things are okay, but the inspection shows that they're not. Are they missing? Is our system missing anything? So that when I take your point that we don't know yet because we haven't done long enough, but in the end, that will be the critical question.
Paul, just let Paul respond to that before you move on. It's important.
Yeah, without a shadow of a doubt, we will miss things with the intelligent monitoring. There will be false negatives. We know that from the 13 already. We go on sites, on ones I've been on with Mike. we will find individual wards that simply weren't picked up as having poor care through our intelligent monitoring. Most of our intelligent monitoring metrics are hospital level, not all of them. Some of them, like the Friends and Family test, do go down to ward level, but fundamentally they are only the top tier of all the intelligence that we have, the ones that are genuinely nationally comparable. So we have a whole set of tests that exclude a bunch of metrics. It doesn't mean we don't use them, but there are undoubtedly false negatives. It will get better. For example, as David mentioned in his update there, when we get the ward level staffing data, that's part of the government's response to Robert Francis, that's something we will be able to feed in. But there is a fundamental difference between all the things that we know before we go on site, which is all about helping pre-populate our views on where to go, and in some instances inform the likely rating, and the judgment that Mike and his teams make. That's a definitive judgment on quality, and that's when we know how good or poor quality is within a hospital, and it is not the intelligent monitoring that does that. That's the smoke alarms.
No, I understand that, and of course there's a process. It just will be important to know the answer and to modify and to and maybe get below trust level data when we, as part of the surveillance. If I could just, I've just a couple of other things about the inspection. I just want to get your early impression, Mike, about the success or otherwise of how we've changed the system. There's got to be a lingering concern that the visits, even though they are much strengthened, are still snapshots of what's happening in a service. A bigger snapshot, or a sort of moving snapshot if there is such a but a snapshot just the same. And if I just give you an example, when I was a medical student, I worked as a nursing assistant in a long-stay asylum. And just to reassure you, this was not in England, so we have no responsibility here, and it was about 30 years ago. But in those days, it was the job of the nurses to give out the cigarettes. So things have sort of improved in some ways, but the way that they were given out was to drop them on the floor so that people could pick them up. And on the whole, people were fairly kind in that unit, but unless you turned up at cigarette time, you wouldn't have got the snapshot you needed to know what was really happening and what people's experience really was like. So I'm not telling you anything you don't know, Mike, but it just is important that the cigarette time in the long-stay asylums is you have that in mind when you conduct even this more robust snapshot. My final point is about is a positive one about about the opportunity that this gives us to do something novel, which is on complaints. We need a science of complaints. At the moment, it is still very much about understanding what's presented in a qualitative form, and that's very variable. The people who complain are not necessarily typical of people who use services. That doesn't mean it's not important, but it means that some voices have gone unheard. And some may be more powerful and prominent than is fair on the service. So a science of complaints, taking these biases into account, is a real opportunity for us to something that we can develop. It's complex, but we've sequenced the human genome, so I guess we can do this too.
Just agree with what Paul was saying. We will miss. We know there will be false negatives. The other point about that, to my mind, is that it's only by inspecting that we get to understand the whys of what's going on within a hospital or a service. And from having done one complete inspection, all days of one inspection, I was uncertain at the beginning of the week. I'd read the data pack carefully. I knew what was wrong in terms of A&E or whatever. Would I, by 4 days later, really understand what was going on in that hospital? I'm sure there are bits of the hospital I don't understand, but I did have a broad understanding that we could feed back to the Trust, and indeed to the Trust Development Authority, which I think was helpful. So I think we get to an understanding as well. Have we changed the system? I can give you anecdotes of what's already been done. There was a porter who had been annoyed that the squeaking door had not been dealt with for 2 years, who came and mentioned it to us. We escalated it, and that door was not squeaking by the end of the day. And we went back and checked. And there are other things as well that we could point to. I agree with you about snapshots. Remember that we are on site for long hours. And we don't just go to a ward in the morning. We may then go back to the same ward that same evening out of hours. So not in our inspections, but in the KEO inspections, I do know of cases where wards said, "Oh, we weren't expecting you back," and so we will do that, and we will go there at whatever times we think there might be the greatest problems. I don't think we have the cigarette example, but we will go, for example, at the handover times to see how well that's done. And we will also do an unannounced visit as well as the announced visit, and that, if we choose that to be at a weekend or choose it to be in an evening, that we can do. On complaints, we've still got a lot to learn on complaints, but we are already using them to point us to which directions within a hospital outside our core services we ought to be looking at. And we're already using the complaints to see whether there is a learning culture. Very simple question to whoever is in charge of complaints or to the chair of the trust. What have you actually changed as a result of complaints? And there are some trusts that have given us very detailed answers to that of fairly major changes that have been made. I can think of one where they have extended the length of consultant time in A&E because of a problem that came up through a complaint.
Take 3 questions. I think we must move on. Anna, Paul, Camilla. I think we must move on.
So I'll be as quick as possible. So 3 questions, Mike, but very quick ones. One is about BART. So I'm really interested how this model worked. Your head of top of the head thoughts about how this worked in such a huge hospital complex, because we were concerned about that. So how did it work? I just want to go back to the point that Kay made, because I do agree, and I had this as well, about the selection of mental health trusts, and I remain concerned. I understand the issues, but I remain concerned that we've got something which is being driven by foundation trust status and not by but by any extent of risk. And I think there must be some proxies. It will be far less sort of robust even than our intelligent monitoring system as it stands. But I just think there must be some ways by talking to some of those people who perhaps particularly represent users of these services to cut through and just identify some places that they think are high risk, and I'd like to see them in this list. And the final thing was about the stuff that we asked you to give us and you've given us, and I absolutely recognise about users and carers being involved in this system, and I absolutely recognise that you have made huge strides and huge efforts to engage with people and to listen to people, because that was a key message of Francis and something you've tried to do here. I think it's really important as an organisation and as a board that we think about this in a strategic way as well as a kind of tactical way in terms of the 3 different hospital inspection routines. So I would really like us to take not too far away, but at an appropriate point, a paper on how we do this across the whole of the inspection regime, what our plan is for engaging users and consumers across the piece.
Deal with the first 2 questions.
Yeah, I'll leave the third one to you, if I may. In terms of BART's, it's a hugely complex trust, and I think it's complex for the trust to run. It's complex for us to assess. I think the parallel teams really work quite well. Whether in the future I would have 3 teams or maybe I'd make it 2, and just for a bit more simplicity. We've also looked at a Heart of England Foundation Trust, which is Birmingham Heartlands plus Good Hope plus Solihull, and we did a single team. I don't think either is completely right. right, but I think what we can do, and we will be doing, is reflecting back on these very, very large trusts, because I think there will be more of them in the future. So we need to get the model right. And my guess is it's halfway between what we did at Heart of England and what we did at Barts that will be right. In terms of going back to those who are FD aspirants versus risk, I think the only point I would make here is we have actually pulled forward the programme to start in January in order that we can get learning, and we've decided to learn on ones that I don't know what risk we will find when we get in. I honestly don't know. All I know is they are aspiring to be foundation trusts. But I can give you an assurance that if we can work out some way of assessing risk from April onwards, we will do high-risk ones then, by all means.
And on the last point you raised, can we bring that paper back to the board probably in January, February, I would think, but we'll, okay.
David, can I add to the point on mental health?
Quickly.
Yeah, I mean, it's worth adding to what Mike said, that wherever those comprehensive inspections are just that, they will eventually lead to a rating. But where we have any concerns about safety, and we do have concerns about safety in some mental health trusts, we will go in anyway. So, for example, we took a team of 10 people into a mental health trust, one particular unit, in September, if I remember rightly. So we're not in any way pausing the existing programme. It's what we do on top of it.
Thanks, Paul. Paul?
This is a comment on really what I've referred to before as sort of the rhythm of what we do and then what others do and then what we do and then what others do. And I was really heartened to hear about the Quality Summit yesterday, because it seems to me this is newer for Monitor and the TDA than it is for us. In other words, they're responding to, yesterday, responding to an inspection and taking responsibility for that response to something much more serious than has happened before. And I think by next time, Mike, it'll be interesting to know about the quality of those responses. Because if I think they're going to need some assistance, not from us, but if on the other hand they fall down, we fall down. I think that's my anxiety here. And I think we've prepared incredibly well for what is something very new. I'm just not sure that prepared. They are that prepared for something that is very new. And that might mean there'll be a stutter in these first few. And the sooner we know about that, I think the better. And I think we just need a discussion around that probably next time.
I think maybe we might have I mean, I don't like joint board to board, particularly there's too many people, but we might have a smaller group from us and with Monitor and just discuss that very point, Paul.
Thank you. Mike, I just wondered if you could tell us a bit about Colchester and what we've learned from it, because the impression from the outside, I think, is that it was quite a lucky chance that a whistleblower happened to point someone in the direction of the problems with the cancer waiting times, and that Keogh and we might not have picked up on that had it not been for that. So I'm just interested in your reflections on that, and also on what we mean by special measures and how you see that going forward.
I wouldn't describe it as lucky chance, although there's an element of that. I think it is the very fact that the Keogh team were on site that emboldened the whistleblower to come forward. And I think that may well be part of what we find with our programme, that will encourage people who've not had the courage up to that point to say anything, to come and speak to the team. So what happened was that the whistleblower came to the Keogh team. The Keogh team escalated it to CQC. CQC undertook a very rigorous inspection of this specific point, and that involved looking at computers and whether things might have been changed on computers. It involved looking through case records and speaking to patients. So did a very a good job there, which did reveal a problem. And at that point, and taking that into account alongside what the Keogh inspection had shown, I think that gave us real cause for concern, which is at the point that I then discussed it with Monitor and said, you know, I think you should consider special measures, because technically the responsibility lies with them. They agreed with this, and actually we issued a joint press release.
And what is that going to mean in practice, do you think? Or what do you think it will mean, and what do you think it should mean?
I think what it means is that they then need to do a much more detailed look at the governance of that organisation, something that we were not doing as part of our cancer weights inquiry, and which was probably done at a level by Keogh, but needs to be much more detailed. I do not know who knew what within the Colchester investigation. That I'm not privy to, but I think that allows Monitor to say yes, we will now look in detail at governance within that organisation.
On that, of course, there's also potentially a criminal investigation taking place that runs alongside that. So the so what question, I think, is a really important one. And I think it then comes into, and this is the willfulness that I think that Berwick referred to, of where you get that kind of willfulness. If somebody has deliberately changed something, then that isn't a support because there's a human error. That is, there's been potentially something deliberate, and that requires a criminal investigation. So I think it's a good example of the balance that needs to be struck, this balance between regulatory action and criminal action being played out. So I think it's worth tracking the Colchester thing as well in terms of the question that you're asking about how that plays through. I think Mike's points about we will get more approaches from whistleblowers who feel emboldened because they know we're coming, and the more publicity has got to this investigation took place as a consequence of some whistleblowing, the more we'll get.
It's also got to be not just the investigation took place, but that there were some real consequences. And that's where, I mean, obviously we don't know that yet. That's where it's got to go, isn't it?
The relationship between what we do and potential allegations we've got that there's a criminal offence, a criminal investigation, and how that goes is going to be absolutely critical.
Good, thank you. I know that we could talk all morning on this, but we can't. So, Andrea.
Thank you very much, because adult social care is equally important, and that's what we got next. What I just wanted to do, you've got the report, and we're really in preparation and development mode around the new approach in adult social care. So there's an awful lot of work that's going on at the moment, which is building on the signposting document, A Fresh Start, which we published just the day before our last board meeting. So what I've done for you is to set out the things that we're doing against each of the priorities that we listed in a fresh approach, which is developing the new approach, looking at the rating system, the monitoring of finances, supporting our staff, and building confidence. I didn't want to kind of cover every last bit, and obviously happy to take any questions. Just to highlight a couple of points. The first is around the engagement and the co-production side of things, and it's particularly important in the work that we're doing, because we'd set out a raft of proposals, ideas that we had, the way that we wanted to go, but we'd also been very, very clear with people who have got an interest in adult social care, so those who are providing, commissioning it, or using those services, that we wanted to develop the firm proposals in co-production with them. So we are running a co-production network group which met for the first time. I thought, sadly, on the day that St Jude's storm blew in, and at 10 o'clock in the morning there was about 6 people, and there were more CQC people than there were members of the group, but actually we had a very full run by the end of the morning. People had made a tremendous effort to get there, and made a fantastic contribution, and similar to the enthusiasm that we were talking about earlier in support of Mike's work, a huge enthusiasm to engage with us. Not everybody agrees with everything, and they don't agree with each other either. So I think that it really does demonstrate that having that development work with people is really important. And our next meeting is on the 19th of December, and very kindly Kay is going to come along from the board to that meeting. So the board will have not just my word for it, but Kay's as well in terms of how that's going. But it's equally important for us to be doing this with our staff. So we have a co-production group that we're setting up with staff within CQC, and I'm getting myself out and about and talking to people about what's happening at the moment, what we can build on at the moment, and what we need to do differently. And two particular issues have been coming through to me, one that Anna's already picked up on, which is using experts by experience, and the board will know that I've been very positive about wanting to expand that. And what's come through, both from the co-production work and from staff, has been a range of views there. Some inspectors who are, kind of wouldn't want to do an inspection without an expert by experience, think they're fantastic and add real value. To others who say, well, actually we've not necessarily trained them as well as we could have done, and it's not as useful as it could be. And equally some experts by experience who have given me examples of where they feel they've made a difference, and others who have said, I don't think I'm really listened to. So I think that it is something that we've got to work on, and that's a very specific thing for us, because I think it's so important. The second area is enforcement, and really trying to make sure that we give a real focus to our work when we say that we're on the sides of people who are using services. Sometimes that means taking action when others haven't. It is absolutely the responsibility of providers to deliver a quality service, but we know sadly that's not always the case, and we need to make sure that people can rely upon us. And again, a lot of discussion about how we can best do that to support our staff to do that effectively, and also to make it clear to providers what we're expecting of them. And the final bit of engagement that I've been doing is a weekly blog which goes out on our intranet and the internet, so both staff and the external world can see how we're developing this up. And again, that's generating quite a lot of interest and support. So something that I'm committed to making sure that we do. So that was just to give you some highlights. Very happy to take any questions, and particularly interested to know whether this as a structure works for the board.
Thanks very much, Andrea. Any questions for Andrea? Steve?
This isn't certainly not a criticism, but I just remain concerned that with the three inspectors in the different sectors, what's being done about across the silos to make sure that doesn't happen. And we've seen from Mike's report that we're looking at a section of community services in January that will have an interface with adult social care. And I just wondered how you're addressing that as we go.
It's absolutely key to all three of us, both in the sense of what are the questions that we ask in the individual inspections that are taking place. So I'm fully expecting that the work that Mike is doing is testing what's happening in terms of integration and coordinated, person-centred coordinated services actually delivering for people, and the focus that being hospitals or community services. For me, obviously adult social care, and Steve will be picking it up in primary care. So we will be testing out those things across the piece. We've also got the issues of thematic reviews, and the focus that Steve will have on integration per se. But I think that it is actually what's really important is us also using the intelligence that we get from each other. And Steve and I, we're only 2 desks away from each other in the open plan, so we're able to have fruitful conversations about this early in the morning. But it's really important about actually for example GP input into care homes and care home liaison with primary care are actually utterly critical, and so those are some of the things that I think that we're very, very mindful of and will be building in. Yep. Thank you. Yeah, I mean it's very, very good report. What I wondered is because in every year we're required to publish the kind of state of care report, and it seems to me that there are kind of wider issues relating to social care. That we obviously regulate services, but there are also kind of wider sort of policy issues. And I just wondered whether you had any sort of thoughts on that, because it's particularly things like, you know, access or equality, that sort of thing, and trends over time. And I just thought, you know, at this stage, had you any thoughts about how we might sort of comment on that?
Can I answer that very? I think the State of Care report is something that we need to do a lot of thought about, to pick up the really big themes running across all these sections. Can we bring that back at another meeting, because it's something we want to address early for next year, if you like. Do you mind, Kay, if we do that? We don't normally take questions from the floor, if you like, but David, you've come all the way down from London, and I can't say no to you. So, please, you know, if you'd like to ask a question, do.
One of the best things about the Transform CQC is the recognition that different kinds of care require different skills in the inspector. And I wonder if Andrea would extend that to different skills for care homes and home care, because that doesn't sort of come so far in what she's published. That hasn't come through. And if she does accept that, then how is she placed for dom care and care home inspectors, and is the CQC Academy doing anything about it? And finally, can we expect quality summits and also sort of regular Health Watch participation in social care, just as in the NHS?
Thank you very much. Well, I hope to make your trip worth it, David, by answering those questions. The issue about differentiation within, we have behind the kind of three main areas of primary care, adult social care and hospitals, 17 different types of service that we will be looking at. And within adult social care, domiciliary care is indeed differentiated from residential care. And Paul's nodding at me, so I know that I've got that right. So within that, one of the things that we need to be looking at is what does good look like? So how do we assess, you know, what the services actually should be demonstrating in terms of being able to answer the question: are they safe, effective, caring, responsive to people's needs, and well led? And actually, I think that some of the ways that we ask those questions will indeed be different between care homes and domiciliary care. Not least because in domiciliary care we cannot kind of go and sit and observe in quite the same way that we can in a care home, or indeed Mike is going to have exactly the same issue in terms of hospitals and community services in terms of making those assessments. So again, picking up Steve's point, there's learning across all three of us in terms of understanding how we do that. Whether that means that people need to have different skills, because we haven't answered question 1, I can't answer question 2, but what I do think that is really important is about the training and the support that we give. And you're absolutely right, the academy and the support that we're going to give to staff has a critical place to play there. In terms of the question about quality summits and Health Watch, we had this conversation, Anna and I have this conversation, and Catherine Rake, Anna's Chief Executive at Health Watch England, we have this conversation, and we had the conversation with respect to the team in Newcastle last night as well. For me, Health Watch, the local Health Watch, are critically important. You know, Mike has already said he's not going to have quite the same level of data available to him in advance of inspections for mental health services and community health services. You know, try doing adult social care, Mike. I mean, you know, we don't have necessarily the same level of data. We do in some places, but it's not necessarily consistent, and it's not necessarily as robust as we would like
like it. So for me, the insight that we can get from Local Health Watch will be really important, particularly in helping to direct where we might want to go and what our key lines of inquiry might be when we get there. So that, I think, is an important thing for us. The Quality Summit, this one's a tricky one. We've got 25,000 locations to review in adult social care. So the sort of, the feedback mechanism, I think, is going to have to be different. There are two things that I would say, though. One is the immediate feedback and the way that we do that with the homes or with the domiciliary services will be important. And we need to make sure that we're working with local authorities particularly effectively around this, because they're the other key players together with clinical commissioning groups for nursing homes. So I think we do have to think about how we make that work. And the second thing is also thinking about corporate providers, so those providers who are actually running a number of services, and how can we provide information back to them across those services. So there is more thinking to be done, but thank you very much for raising the question.
Thank you. Be right to pick up your question later. You should. We're getting.
Can I have a mic, please? Or I just talk louder. Right, I heard your voice say you cannot ask a question. It's only the board member can ask a question. That's not fair.
No.
Right.
I was going to say at the end of the.
No, because you know why? I hate it. He put three hand up. He didn't answer. He looked like that. I don't like it. At the end of the session. He said, but the chair didn't say that.
No, I'm sorry, I didn't explain well enough. No, at the end of the session is normally when we have questions. No, during you can. Yeah. Okay, we'll come at the end of the meeting if that's all right. Thank you. Can we move on to Steve? Your report, please.
Thank you. I've tried to lay out in the paper very simply where we are. Inevitably, this is about process at the moment. At the next board, hopefully we can talk about some of the outcomes. By the time the next board meets, we will have finalised the signposting document for general medical practice, and also a report on the first 1,000 inspections which have happened since April under the old system. A number of those are revisits, and we'll be able to quantify where we are with that. And it would be useful then, I think, just like we talked about Colchester, to talk about the outcomes and the effects on patients and how we're going to evolve and learn for the new system. I'm more interested in the outcomes than the process. I spend every day on the process. But I would like to say something about patients. I mean, I believe I'm here for the patients, the carers, the future patients, but also the next generation. And some of the things we're finding in general practice in small numbers could affect the next generation, not just the current generation. For example, if we're finding issues which affect pregnant women, they could have a bearing on the next generation, and therefore they're very important. Whilst hospitals inevitably we spend a lot of time on hospitals at the moment because they're in the press and Mike's ahead and doing a fantastic job, we need to remember that an error or a problem in general practice can affect many hundreds of patients. And that might not be the newspaper headlines that we've got, but we're here to support and protect patients and make sure that the services are, as Andrea said, well led, caring, etc. So from a patient point of view, the model for us will be that we'll be going into each of the local CCG areas every 6 months. And inevitably, that means that we'll have a closer contact with local people through patient groups, through Health Watch locally. And I was hugely impressed yesterday coming up to Newcastle with the fantastic staff and the way they handle the calls and the complaints from the public across England, but also the discussions with the chair of Health Watch Newcastle really reassured me that we can really motor on this very quickly. But if we're going to meet with local people at least every 6 months, probably meetings across the year, that will inevitably have an effect on Andrea and Mike's work, because we'll be picking up information about social care, hospital care, mental health, community care at the same time. And I think we need a little bit longer to consult and work on that, so that we've got a model that really works. We are also looking at starting the work now on how we rate general medical practices, particularly with a priority on elderly, vulnerable elderly people over the next 6 months or so. And on the first page of the update, you'll see that the breadth that I've got to sort of look after means we do have to prioritise. There's some brilliant work going on in CQC, which often doesn't get exposure. For example, the work with health and justice and prisons is really, really good work. And for me, because it's really good work, we can support the staff and move on to the new areas that we need to prioritise and come back to some of those areas later on. And that's all I'd like to say. Just that I'm hugely impressed by the support I'm getting, but it's very, very early days.
Thanks, Steve. Anna?
Thanks very much. So very much welcome that emphasis on the use of service, Steve, as you know. So, but to move to something else. So, you and to join up with the conversation that went on earlier about the relationship between the 3 inspectorates and the need always to keep in mind the pathways and the kind of the people-centeredness of our approach. And I know that falls to you, Steve, particularly in terms of your responsibilities for integration. But I just, this is, I guess, a challenge to David and the senior team, really. I just wonder, when we take reports from the executive, if we shouldn't be looking at some point in the near future to having not just the 3 reports from the chief inspectors, but a 4th report into which all of the chief inspectors will need to feed, plus of course Paul's thematic team, which specifically addresses those kind of cross-cutting issues which have emerged and which are of significance to consumers and users of health and social care, so that we get a kind of broader picture of what's happening. And I guess just make sure that people's minds continue to be focused on the joins and not just on the sectors.
If I may, I think that's the intention. As we go into the CCG areas, we will get feedback from care homes, from the hospitals, from GPs about services and the handoffs within a local area. So I think in future there will be 2 key ways of doing this. One will be locally, in local areas, looking at the joins. So one of the areas you might suggest would be medication prescribing and administration between GPs and care homes, which we know is a high-risk area. Now, that might be something we end up doing just as a routine and a regular piece of work, but we should be looking at what the issues are, particularly following the NICE guideline production soon. But there are lots of others: mental health care, crosses, general practice. Actually, most mental health care is in primary care, not in mental health trusts. And so we're inspecting trusts, but in fact most people don't live in hospitals or are in hospitals or in acute units. So it inevitably will have to be joined up, and I fully expect GPs to be going on visits with Mike's teams as well as Andrea's teams, particularly if we can target what the issues are. And then there's the second issue, which I think is really important, which Paul leads and chairs, which I think is entirely appropriate, where we select as a board, after consultation, key national themes that we can look at across the whole country. And what we've been doing, again, it's a bit boring, but it's the process of how we set up the teams and the numbers, is to give some time so that all of our inspectors can cross all of the 3 inspectorates and be involved in those big national themes. And my belief, and I know it's David's too, is that that should drive a new way of looking at the state of care report on what's happening across our country. But again, I think that's for a later day because it's a bigger debate.
I mean, just to say the obvious, that it's a huge number of areas that you've got to cover. On the acute sector side, we've got the surveillance system to try and help risk stratify. And it would be useful to see, because safety is clearly number 1, I would think, of our priorities. It would be useful to see an explicit framework of risk that could help direct your priorities here. which is not quite akin to surveillance but is parallel to it.
Indeed, and we're just starting with Paul's Directorate and with some external support to work on that. The work will be kicked off next week.
Any other questions for Steve? Can we move on then to the performance report? Paul, I think you can do this fairly quickly. You can assume we've read the paper.
I will do. So this covers performance report and the finance report and the strategic risks. If I just note, in the Q1 report, there was some erroneous data, and I apologise for that. David, I think, has sent round a briefing separately explaining that, but it relates particularly to the Q1 13-14 figures about numbers of providers who have been non-compliant over long lengths of time. For example, we reported 266 when it should have been 967. So the headline implication is that although we had thought we were seeing a reduction in long-term non-compliance, that is not the case. Just if I pick out briefly some of the more positive messages that we're seeing in Q2, I'd start with the fact that we are now starting, as of mid-November, to issue fixed penalty notices to providers who have not had a registered manager in place for a long period of time, and that's completely unacceptable. And that's something the board has commented on in the past. Our warning notices, so our enforcement action, is up at 48% more warning notices than for the same quarter last year. Overall, we're on track to complete the programme of inspections. As we've discussed, activity is by no means everything, but it's important we deliver on that commitment. And we've deliberately built in 3 weeks of headroom into the inspection programme for 13-14. And each region is confident that it can deliver on that 49-week timescale. And we are on track financially. In fact, as I'll come to, we have a slight underspend. In terms of the concerns, we've not been able to improve the speed of report writing. We have a metric around 25 days for all of our reports following inspection. And although that is relatively close to that outside the acute sector, we're only at 35% within the NHS. That's due to the complexity and due to the fact that we use more experts by experience, but nonetheless, it's something we need to recover from, and we're putting recovery trajectories in place across the country for that. Our registration timescales are also up, so we want to reply to everybody within 8 weeks of application. We have seen a significant uplift in the number of applications. One thing that we are doing on that, we've recently moved to online services for GP registrations. We know that's improving the performance, and we're looking to roll that out across all our sectors over time. We have concerns about the speed of response on the second opinion appointed doctors, the SOADs, and that's covered in the paper. And that's largely related to making sure we have enough SOADs. It is difficult to recruit them, but we have a plan in place to do more. And if I turn briefly to the underspend, that's 6.1 million on forecast, and is largely driven by getting additional people into post quickly enough. And we continue to monitor that. We also have a capital underspend. And finally, we're making sure that we track our risks. We've had conversations at the board about our risks. We've added some more risks to the strategic register, but we do believe we have the right mitigations in place for that.
Thank you, Paul. John?
Can I just ask a very quick question about the revised paper which was circulated, where we had to go through the little exercise of working out what the changes were. And I can tell you there on paragraph 5.1 and 5.2. And in particular, it draws attention to an estimated £7 million underspend of capital, which is not shown in Annex B. We have to return our estimated end-of-year data forecast to the Treasury, and if we don't get it right, we need to explain this to the Treasury, which is understandable. But my question is, if we don't use the £7 million capital, does that mean the Treasury is going to reclaim that so that we won't be able to use it in the future?
Yeah, no, to put too fine a point on it. Yeah.
And is there an implication of that?
there is, like any underspend, there's a potential implication, and the balance in this is have we got plans to spend this money? Are those plans robust? Have the appropriate has the appropriate work been done? The business cases prepared, etc., etc. And there are capital implications for the work. We need to do that work. I think one of the themes for today is just how quickly we're running and how just in time a lot of this is, and therefore working out the precise detail for things like capital investments is challenging. I don't wish to be defensive at all, but by the same token, it will be just daft for me to say we've got plans where we haven't got plans, and I don't think ideas are plans. So I think we need to get this into a set of plans on the capital. In relation to the money for transformation, it's like an overdraft facility, John. It's a drawdown, really. We've not been given the money. What we've got is an ability to spend up to that money, and we will be given it by the department if we spend it. So, again, one of the themes of this morning is I think it's a bit like an aircraft taking off along a runway. We've gone down the runway, we're off the ground, the trajectory, we're gaining height, and I think we are going to, as we bring in the capability and capacity, going to end up spending some of this money. I don't think we're going to spend all of the money, and actually I'd be worried if we tried to spend all of the money, because what we need to do is make sure we spend it on the things that we need to do. So my aim is, and I think the wording was quite carefully chosen, is actually spending this money appropriately rather than spending it, and
I think
that's what we're trying to do.
I think the analogy is very helpful, but actually, if I can take it a bit further, it is about making sure that the aircraft, when it is taken off, has enough fuel on board to get to its destination. And that's the question I'm asking. I want to be reassured that we're actually going to get to the destination that we're heading for.
Yeah, it's a good question. I mean, the Department of Health and the Secretary of State have said they are fully behind what we're doing, and so long as we are sensible in what we ask for and how I think we have that support to do it, John. Any other questions on that? Just very quick, Kay.
Yeah. Paul, you mentioned that the getting reports done in time was still sort of not on track, and I just, I mean, it is obviously something we need to sort out, but I am sort of not convinced it's simply about sort of cracking the whip, and it might be about doing things differently, because, we've learnt, generally that sort of targets and relentless pursuit of targets can be counterproductive. And so if we don't meet a performance indicator, I'm not, obviously ideally we would meet it, but I would be more worried if we were sort of cracking the whip for our inspectors who are working very hard, to get them to do something that actually is counterproductive. So it's some sort of reassurance, if you like, about, how we measure our performance in a way that's not counterproductive. Yeah.
So I suppose one way we could have gone about this is to say it's 90% is 90%, now get on. And we really haven't taken that. When I say we're developing local trajectories, that's a sort of probably unnecessary shorthand for saying we're having there's a conversation going on about why. And some of these are unavoidable. These are, as we do more in-depth inspections, and not just through wave one to take the hospitals, but in our existing programme, we are simply putting more people into trusts and often in adult social care as well. They are more complex and more people to draw information from. We often make more challenging judgments that requires more factual accuracy checking, so on and so forth. So there are legitimate reasons. So in each case, rather than saying there should, we feel there is now a blanket target, regardless of sector and regardless of complexity. Each of the areas of the country that we split up into operationally are looking at what a reasonable sort of recovery path looks like that strikes a sensible balance between why these things take longer and equally understand we do have some commitments that we should meet to the public on this.
Quick last one from Camilla.
I'm delighted to hear David say that we should never spend money if we can't spend it wisely. Brilliant. Just on Kay and Paul's point, I really do think this is a classic, isn't it? It's sort of the danger of perverse incentives. I mean, we need to be defining how we measure success, don't we? And ultimately, our success is not about how many warning notices we've handed out, and it's not about how long it takes to write the report. It's about the quality of the report. Has the inspector been able to exercise their judgment? Have they been able to go back in? Have they had the flexibility to go? I mean, I've been with a couple of inspectors. I was shadowing an inspection 2 weeks ago. It was very important to him that he had an instinct about something, and his manager said, yes, okay, you can go back. Not to say you've got to complete by Friday. And ultimately, have we improved the service? And I know you know that, but I just think when you see a sheet like this, I become a bit alarmed. That's not what we're measuring.
So I just couldn't agree more. So we're doing the thing that David talked about in the past. We're both trying to deliver the existing commitments that we have and completely change the way we work. Part of that is to lift off and say what are the things that actually matter. And we've talked about a dozen strategic measures that are all linked to the end state of people getting better care. But track back from that about having rigorous and robust judgments. And it is important that they're timely as well. So that we know this report isn't exactly where it needs to be. We need to sign off what the big measures are. I think we've had conversations where we're better off changing the model and then completely changing the report, and in the interim up to April continuing to basically report on this basis, but completely on the understanding that it isn't activity that matters, it's quality.
I think we're all at one on this, but in terms of restructuring this report, because it will be restructured completely along the different way that we are organised as well. We'll do that for April of next year. Any other business before we turn to the members? Any other business from the board? Normally we break for coffee and meet everyone over coffee, but if anyone has got a burning question they'd like to put to us while we're still got the cameras on, so to speak, please do so. Otherwise we're all available to talk over coffee. Yes.
I'm involved with this place. Patient-led assessment of clinical environment in Newcastle here. I do both Thumb, Tenin Weir, mental health hospitals and Newcastle Fontaine mental health, ordinary trust in Newcastle here. And we've done a damn hard job last year going, like for instance up at St George, 10 wards in that inspect. It's hard work, all voluntary, and I found it thoroughly great, working with top sisters and things. I'm lead on the patients. And good thing, I'd just like to hear it. I never heard it mentioned, but we are equal to Health Watch, incidentally. We do just a good job. So second from the top in the red there. What do you think of it, please?
I didn't hear the last bit.
Yes, that is. Well, you mentioned Health Watch before.
Yeah. I mean, I think that what we need to be doing is engaging with all of the groups that actually can provide us with insight into what's happening locally with regards to mental health services or adult social care or whatever else. Mentioned Health Watch because that's a very specific organisation that's been set up, but it's not the only source of information.
Like I say, patient-led, we are.
Yeah, well, and we are very, very keen to make sure that we're listening to the voices of people who are using services and also their carers and families to make sure that we get the broadest possible understanding of what's happening and what we should be looking at. So thank you very much for your efforts.
Just waiting for the results from you. Thank you.
Excuse me, my name is Susan. I've been to the hospital to see my husband, and now you do a very good job now because my husband in the hospital 48 tablets a day. I cut 46, and I've been complaining about the hospital not do right. Every time I see my husband and all the man there, he say, "Oh, it's good. You're coming. We can talking." The people ignore me. What? When the HUK that year, I complain about it. They do the thing right now. The hospital do it very good now. Ignore that patient, that's not right. I mean, upstairs, on top of the street, the man was 48 tablets, he died. The top of the street, they died. But my husband, I won't let it. I told the doctor, I'm sorry. He cannot take that 48 tablet. The first tablet, his face numb, I take it off. Second tablet, he cannot go to the toilet. And the third tablet, he's like a dummy. No, I hope the doctor check it properly. Might be not the doctor, might be, somebody make a mistake with the tablet. Now I take 46 tablets off. He got 2 tablets. And the second thing I asked, his feet was like swollen. I asked for the stocking. Oh, sorry, we need to order it. Why? It's hospital order stocking. No, I'm sorry. When the doctor come, I say, I want a stocking. They put a stocking on. I'm do the job, push the stocking up. I'm not young, I'm 75. I sit on the floor, push up. Now it's really good. The feet is going down. I'm very pleased. I'm so pleased. But the hospital need to be better now. I think the people need to complain about what's going on. But the people didn't say anything. I'm on the street asking the people, you know what they said? My mom died last week. Was 100 people die like that? That's not right. That's why I tell you off, because that gentleman put a hand out. He look like my granddad. I feel horrible. Sorry, dear. No, he should. No, he should say, oh, sorry, put your hand down. Wait for the board member meeting. I scream. And everybody really like to put everything in. It's all right. Now, Michael, I hope you do the right job. If the next time you saw me, I come up to see you about this hospital. Thank you. Sorry about.
Thank you very much. Thank you. I think we'll.
Can I just make one comment about the impression? I'm an expert by experience, by the way, and I came today to hear how things are moving on, and they are moving on. But I must say, your administration is very, very bad. When I hear that you're underspent by a budget of 6 million or something, you've got money that you're not using. The administration really needs a good looking over as soon as possible, because you need the administration as well as the front line, and they don't seem as if they're working together. So please address your administration as well as all the other things that you've talked about today. Please.
You're very good to make that point. I would just say that the underspend predicted for the year is 2.1 million for the year. So it's
still underspent.
It's underspent, but better to be underspent than overspent. But nevertheless, you make a good point. So thank you very much for that. Shall we break now and have a cup of coffee? You're very welcome to join us for coffee next door. Thank you.